So welcome everybody to this webinar. I'm Caroline Fichtenberg, a co-director of the Social Interventions Research and Evaluation Network, and we're going to be hearing today about some really interesting research about how to provide social needs screening and referral interventions over the phone. Before we get started, and while we're waiting for folks to trickle in, if we'll go to the next slide. For those of you who aren't familiar with Siren, wanted to just give you an overview of who we are. So we are a research and dissemination center at the University of California, San Francisco. We've been around for about 7 years now. We focus on improving research on social and medical care integration and also on helping to disseminate that research. We do three main things. We synthesize and disseminate research, we convene stakeholders, and we conduct and catalyze research. On the next slide, I want to make sure you all are aware that we host an evidence and resource library that is a searchable resource, basically a database of all sorts of research and implementation tools about healthcare-based social determinants of health interventions. And the link is right there on the slide. You can also just search for Siren, UCSF in Google, and you'll find our website. And I also want to mention, if you go to the next slide, our Siren monthly newsletter. If you're not already getting it, it's really a great way to stay on top of the research in the field. We send it out every month, and we send out a list of all the research that's been published since the last newsletter. So it's really a great way to find out about what we're doing, but also what's happening in the field in general. Let's go to the next slide. So for today's webinar, I want to reassure everybody we are recording this webinar, and we will make the recording available to everybody. It'll be emailed to you next week. We'll also share the slides. You can actually access the slides already. If you go to the bottom of your screen and you see something that says resources, that will pop up a window where you can access the slides. You want to look for documents, and the slides will be under there, as well as the two publications that this presentation is based on. Because we have potentially a lot of people joining us, about 230 right now, we have done this in a format where, unfortunately, you're all muted, but you can please engage with us through the Q&A feature. Any questions you have for the panelists, please put them in the Q&A and feel free to respond to each other's questions. If you have things that are more like comments, you can use the chat function for that. So again, use the Q&A for any questions you want to ask all of us. Use the chat to basically put comments out there that you want other people to be aware of. Lovely to see everybody introducing themselves. And want to also, we'd be remiss if we didn't also thank our very generous funder, the Robert Wood Johnson Foundation. So as we're getting started, there's a poll that just popped up. We'd love to know who's in the audience. So if you could go ahead and fill that out. And we know that some of you might have multiple affiliations, but just pick the one that it feels like the most, the one that best describes what you do most of the time. We're going to let that go just a little bit longer. So we get about maybe 75% of people participating. And then I think let's go to the next slide. So while people are still maybe filling out the poll, we're really excited today to have a presentation from Anna Steeves-Reece, who is with OCHIN, about how to improve phone-based social needs screening and navigation. And she is joined by 3 of her research colleagues. And I will turn it over to her in just a moment, but first I wanted to just end the poll. Thank you so much for filling that out, and we'll share the results with everybody. Hopefully everybody can see this now, that we have about 35% of folks who are actual service providers, about 20% researchers, and another 24% who are more kind of administrators or managers in healthcare social services. This is really great. We love also seeing the 9% patient advocates that are there. So thank you all for joining us. And I'm now going to turn it over to Anna for our presentation. Anna, the floor is yours, and we're going to pull up your slides in just a second. While we do that, if you want to go ahead and introduce yourself.
Yes, and I'm very excited to see, healthcare providers, direct care staff that are on the call today. So thank you so much for taking time out of your very busy schedules to be here. So thank you again for joining. Thank you for Siren for inviting us to share our work. My name is Steeves-Reece. I'm currently a health services and public health researcher with OCHIN. But the two studies we'll be presenting on today were components of my dissertation research at the Oregon Health and Science University, Portland State University School of Public Health in Portland, Oregon. My dissertation was meant to focus broadly on patients' perspectives regarding social needs screening and referral interventions. But as you might imagine, the COVID-19 pandemic naturally prompted a much greater emphasis on patient decisions, experiences, and recommendations surrounding phone-based social needs screening and referral in particular. And I'm joined by Melissa Frangie, Katherin Gómez, and Minnie Kang, who were all analysts for the qualitative study, and they were also social needs screeners for the Accountable Health Communities model in Oregon, which was the intervention of focus for both studies. So I'm extremely glad that they were able to join today, both because of their roles on these research projects, but also the many hours that they spent talking to patients about social needs over the phone. And I know that some of you on this call do that as your job. So I'm especially interested in your thoughts as they relate to these presentations and our findings. Next slide, please. So starting with some background on the intervention, the Accountable Health Communities, or AHC model, is a social needs screening and referral intervention that was developed by the Centers for Medicare and Medicaid Services. And participants were community dwelling Medicare and Medicaid beneficiaries accessing care at participating clinical delivery sites, which were all across the state of Oregon. Consenting beneficiaries were screened for social needs related to 5 domains: food, housing, utilities, transportation, and interpersonal violence. Those who screened positive for one or more social needs were offered a community resources summary. And those who screened positive for more or one social needs, plus self-reported 2 or more emergency department visits within the previous year, were offered additional navigation assistance, plus the resources summary. Next slide. So there were 28 bridge organizations across the country implementing the AHC model intervention. The Oregon Rural Practice-Based Research Network, or ORPRN, at OHSU was the implementing organization for Oregon. And ORPRN was responsible for identifying and partnering with various clinical delivery sites to adopt the intervention, aligning Accountable Health Communities model partners to optimize the community capacity to address social needs, and also data collection and management. Next slide, please. So the first study that I'll present on was published in the Journal of the American Board of Family Medicine: Patients' Willingness to Accept Social Needs Navigation After In-Person versus Remote Screening, a cross-sectional study. And our objective was to assess whether in-person versus remote, for example, calls or texts, social needs screening, modified associations between patients' total number of social needs and their willingness to accept resource navigation. Next slide. Eligible participants for the study were Medicare and Medicaid beneficiaries who had participated in the Accountable Health Communities model from October 2018 through December 2020. Our study focused on those who had met the criteria to be offered resource navigation assistance, which they could either accept or decline. Next slide. Our analysis was testing whether 2 people presenting with the same number of social needs would be equally likely to accept resource navigation, whether they were screened in person or remotely. So for our analytic approach to that question, we used logistic regression with clinical delivery site fixed effects and clustered standard errors. Our dependent variable was whether beneficiaries were willing to accept resource navigation. And the main independent variable was an interaction term combining patients' total number of social needs plus screening mode, in-person or remote. We selected confounders based on literature review and bivariate analyses, And we created a dummy variable for the COVID-19 pandemic, which we included in sensitivity analyses, but we didn't find that it substantially impacted the results either way. Next slide. Thanks. So ultimately, our sample included 653 beneficiaries who were screened for social needs in person and 851 beneficiaries who were screened for social needs by phone. The next slides compare demographic differences between beneficiaries who were screened for social needs in person versus remotely, as there was considerable overlap between a switch to phone-based screening with the COVID-19 pandemic. Several differences are apparent between these two groups. Next slide, please. Regarding social needs, in the orange bar graph, a lower proportion of those screened remotely versus in person had only one social need, 26% versus 39%. Also in the lower graph, a higher proportion of those screened remotely accepted help with resource navigation assistance, 77% versus 63%. Next slide. Regarding ethnicity and race questions, a higher proportion of remote participants identified as Hispanic, Latino, or of Spanish origin. More remote versus in-person participants also selected Native Hawaiian and other Pacific Islander, Asian, Black or African American, and other and multiple categories. A higher proportion of in-person versus remote participants selected American Indian and Alaska Native and white categories. Next slide. So in the blue, those who were screened for social needs in person had a slightly higher mean age, 43 versus 40. In the purple, a higher proportion of those screened remotely were male. In the green, a similar number of remote versus in-person beneficiaries reported annual household incomes under $10,000. And in orange, a far greater proportion of those screened in person versus remotely had a rural or frontier zip code. Next slide. And finally, a slightly higher proportion of those screened in person took the screening on behalf of themselves. Next slide. So in the full model, as with a lot of previous research, there were strong associations between a higher number of social needs and greater likelihood of a willingness to accept resource navigation assistance. Next slide. And we found that neither screening mode nor the interaction term combining screening mode plus patient's total number of social needs were significant, though the confidence intervals were very wide. In other words, among patients presenting with the same number of social needs, we did not find evidence to suggest that screening mode will adversely affect patients' willingness to accept help with navigation assistance. Next slide, please. So the implication of the study, which is, likely most relevant to this audience, is that healthcare organizations may choose to start or continue screening patients for social needs remotely, knowing that there is not evidence that doing so will adversely impact patients' willingness to accept navigation. There also may be additional incentives for remote screening. First, limited time during clinical visits makes remote screening potentially more feasible. Second, those with a higher number of social needs may also be less likely to attend in-person appointments. So if screening is only happening in person, those who most need assistance may be missed altogether. But of course, remote screening could still have adverse implications for health equity that should be accounted for, especially for people with limited English proficiency and technological barriers. I'm now going to pass things over to Melissa, Katherin, and Minnie to present on our qualitative study. And I'll just say that I think that that study is particularly relevant for thinking about how social needs screening over the phone can generate positive patient experiences. Next slide.
Thank you. Good afternoon. Buenas tardes. Thank you for having us. We will be sharing our second study that was recently published in the International Journal of Environmental Research and Public Health, and it's called, quote, "It made me feel like things are starting to change in society." a qualitative study to foster positive patient experiences during the phone-based social needs interventions. So the purpose of this study was to assess patients' experiences and recommendations regarding the Accountable Health Communities model. Next slide, please. Thank you. So interview participants in this qualitative study were Medicare and Medicaid beneficiaries who had participated in the Accountable Health Communities model in Oregon. All interviewees had qualified for resource navigation and accepted navigation assistance. We decided to focus this study on the people who were both screened for social needs and eligible for navigation assistance over the phone. We recruited patients who have gone through the intervention out of 2 clinical delivery sites, an emergency department and a federally qualified health center. This study was approved by the Institutional Review Board at the Oregon and Science University, OHSU, and all the participants provided verbal informed consent. Next slide, please. So our study was guided by a pragmatic paradigm. And in other words, we place emphasis on an approach that was democratic, collaborative, contextual, and action-oriented. So first, our interview guide included questions about participants' health, what they remember about the Accountable Health Community screening call, also their experiences with any follow-up activities, and information about whether and how they were able to make research connections. The interview guide was translated into Spanish by an IRB qualified translator. Then we purposefully recruited eligible participants to include a wide range of experiences and perspectives and identified themes that transcended a diverse sample. So we saw a variation across multiple characteristics and circumstances from which we have data, including the patient's age, sex, race, ethnicity, and primary language, English or Spanish, and the types and total numbers of social needs. Lastly, we use reflective thematic analysis to develop the themes for the qualitative data. Next slide, and I'm going to pass it to Minnie.
Thank you. So from late August through mid-November of 2021, we attempted to contact 92 beneficiaries, of which 34 or 37% participated in interviews. The sample included a wide range of demographic characteristics in terms of race, ethnicity, language, sex, and age. Next slide. So of those 34 participants, all 5 social needs from the Accountable Health Communities model were represented, including food, housing, transportation, utilities, and safety. Interviewees had self-reported between 1 and 4 social needs. Next slide. Regarding the Accountable Health Community model outcomes, we determined through the interviews that 26 interviewees remembered the social needs screening call, 20 received social needs resource information, 14 outreach to 1 or more social needs resource, and 9 interviewees accessed resources for social needs as a result of the intervention. Next slide.
And then next, we developed 6 themes through our reflexive thematic analysis process. First, participants told us that they were or that others would be initially somewhat skeptical due to receiving a call from an unknown number, especially with the existing phishing scam. And a 45 to 54-year-old Hispanic female shared, quote, "I am very inquisitive when it comes to that. At first, I ask, where are you calling me from? Why are you calling me? Not just anyone is going to help a person. Sometimes they just do it to grab your information." And interviewees also share that or also talked about how the sensitive nature of the social needs screening questions can make people hesitant to participate. For instance, a 65 to 74-year-old white female said, "With my daughter's disability, there was a Department of Human Services involved quite a bit in our household. Maybe it would have caused her more problems to admit to some of this stuff." Next slide, please. And for our second theme, participants explained how immediate transparency regarding the purpose of the call was helpful in moving from a place of skepticism to understanding that the call was legitimate. An under 25-year-old white female said, "It seemed like a scam at first, but because I know the healthcare system and I've been going there since I was like 2 years old, I was like, there's no way that this is a scam." And then ongoing respect for autonomy was also valued by participants. A 45 to 54-year-old Black male described it. "I mean, I don't want to be hassled if I have to tell them that everything is good. If I'm not in a good place, I'll ask them. I don't want to be pressured or hassled." Next slide, please. And then for theme number 3, we found that the showing of kindness for the patient through one's own demeanor was very important. Multiple aspects of the caller's demeanor were indicative of kindness to interviewees. Like listening, gentleness, and patience were some of the qualities that participants picked up on the most, and typically through the caller's tone of voice. As an under 25-year-old Hispanic female said, quote, "The tone of voice she maintained the whole time was really helpful. Just maintaining maybe a soft, it doesn't always have to be soft, but just like a calming voice is very stereotypical, but it does work." And then similarly, interviewees could easily pick up on a lack of kindness through the caller's tone. A 55 to 64-year-old white female said, quote, "She wasn't very kind too, just quick and short. The tone in her voice, it seemed like she was in a big hurry. I had the feeling she didn't have her morning coffee. There was just no life and no concern and no personal interest in what she was saying." Next slide, please. And fourth, demonstrating a genuine intention to connect to patients with resources mattered. Participants said that their motivation to engage with the social needs screening was affected by their impression that the goal of the call was to truly connect them with resources. As a 45 to 54-year-old American Indian or Alaskan Native put it, "As long as I think it's going to help me and not hurt me, I'm willing to answer the questions." Another example was captured by the following exchange between the interviewer and a 45 to 54-year-old Hispanic male. First, the interviewer asked, "Is it okay to talk about social needs even when help or resources cannot be guaranteed?" And then the interviewee responded, "It depends on the person. Look, there are times when if they're going to help you, that's fine. But if they're just one of those people who doesn't want to help, they will not explain it to you." And then the interviewer clarified. So more like what their intention is of the person, and the interviewee agreed, yes. All right, so next slide, and Pat, I'm passing it on to you.
Thank you, Melissa. So I will continue with the next 2 themes. So our 5th theme was the degree of attentiveness and responsiveness that callers gave patient circumstances and requests impacted their experiences, participants were pleased and participants were pleased when there was an accordance between their requests and they had made subsequent actions. So a 25-year-old Hispanic female agreed that she probably would not have applied to the bus passes if she hadn't received help filling out the necessary paperwork. She explained why she probably wouldn't have reached out for help, saying, quote, "I am really anxious about stuff like that, especially in regards to paperwork and legal stuff. I would have been too afraid of doing it wrong." Also, a lack of attentiveness and responsiveness could leave participants with a negative impression. A 45 to 54-year-old Asian male shared, quote, "Well, I told him I live in County A, so do you have anything for County A? But they gave me the number for County B, and that's the problem. I don't need County B." Next slide, please. Finally, our sixth theme was the patients could be left feeling appreciative or helpful, whether they access the resources or not. So I'll start with those who do not access the resources through the intervention with a quote that it might sound familiar to you because this is where we got the title of this paper. So a 25 to 34-year-old Hispanic female said, quote, "I was happy to be asked the social needs screening questions because it made me feel like things are starting to change in society. I really felt important and like things are starting to change." The next quote was from a 25-year-old white male that shared, quote, "The way that my situation was handled, it went above and beyond what I needed even. Honestly, I didn't know that it was something that healthcare organizations took care of. I mean, it's more of a well-being business, you know, as opposed to just help. It was something that I didn't realize you guys did." Next, I'm gonna share a person that access resources. Thank you. So this is a quote from a 45 to 54-year-old multiracial female who did access the resources. And this is what she said, quote, "It's giving so much hope and kindness because of COVID, because of my heart condition and my health condition. I have to stay away from people. I don't have the vaccine yet because of my heart and everything, so I'm not as social as I used to be. And some people, their lights go dim. And you guys are like the lighthouse on the beach saying, here's the light, and I'm gonna try to shine it to you." That's the end of the quote, and I will pass it back to Minnie.
Thank you. So we use those 6 themes to create our framework for fostering positive patient experiences during phone-based social needs screening and referral interactions. These themes correspond with different time points of the caller-patient social needs screening and referral interaction. For example, at the starting point of the interaction, patients may rightfully feel skeptical or have reservations. Callers can then do a variety of things to foster positive patient experiences. They can practice transparency and respect for autonomy, bring a kind demeanor, demonstrate a genuine intention to help, and be attentive and responsive to the patient's circumstances and requests. If callers can put these activities into practice, patients can be left feeling appreciative or helpful at best, or neutral about the interaction at worst. While the goal of these interventions is often to connect patients with relevant resources, first and foremost, it is also critical that healthcare organizations train callers on practices that can help with avoiding harm during these interactions. Next slide, please. So regarding the implications for practice, healthcare organizations may use our framework to train those who will be calling patients for social needs screening and referral interventions. Also, it is important that healthcare organizations create conditions in which callers can do this work more effectively. For example, ensuring that callers have enough time to foster positive interactions and building partnerships with community-based organizations so that referrals can be made with greater ease. Next slide.
All right, so that's our presentation, and it looks like we've left quite a bit of time for questions. I've done my best with the Q&A in the chat, but happy to take any other questions either in the chat or verbally.
Yeah. And I wonder, can I just double check with participants? Do the participants see the answers that Anna has typed? I think in the past, maybe you don't. People are saying yes. Okay, great, great. Well, folks, please feel free to ask more questions as we go there. And then I'll start us off with one question. I'm really curious. I think you kind of explained it a little bit, but I'm curious the title of the presentation or that talk. You know, I feel like things are starting to change. Can you say more about what you think that person meant?
Yeah, that's a great question to start out with. Yeah, there were a couple of quotes that I thought about using for the title. I mean, I think one that I included in this presentation that's not in the manuscript was the one like, I didn't realize this is something that healthcare did. And yeah, I think that a lot of people that we spoke with, well, I guess I just want to be upfront about my own skepticism going into this research. I think that that's helpful context. So when I was kind of, you know, setting up this dissertation initially, there was very little coming out on patients' perspectives at all around social needs, screening and referral interventions out of the healthcare context. And I think myself, along with a lot of others, had a couple of reactions. One, like, you know, primary care is known about social context and involved in care for a really long time. And like, you know, is screening and doing it in this kind of systematic way something that patients even want? We're not hearing patients' perspectives on this. And could this even take away from patient-provider trust? Could it lead to unintended consequences like discrimination? You know, like I really went in thinking that I would talk to patients and they would not be happy with these calls potentially. And I was surprised with how many people shared with me that they were just like, I was just so glad to have someone take the time to call me and ask me what's going on in my life and acknowledge that those things impact my health and to really take the time to listen. And I think that whether or not someone listens to someone can happen either on the phone or in person. So it's not so much like the mechanism is what I found, but just like that there's a space being created to do that with a person. So I don't know if that fully answered your question, but I think just, you know, what it captures to me is the surprise that I had, but also that I think the people that we spoke with had about healthcare organizations caring about this and including it in a systematic way as part of primary care.
And I had some.
Yes,
please, Katherin.
Thank you. So through the pandemic, there was a lot of isolation and people didn't really know where to access resources. So hearing this person saying like, oh, it was nice to hear that, you know, things are starting to change. It was, I think for me, it was very valuable to see and hear people, what they were experiencing and going through and sharing those resources, right? Because for me on my end, I'm making the phone calls and then when I hang up, that's it. Like, I don't know if they answer, they reach out or receive the community resources. So through this follow-up, it was really nice to see that patients were appreciative of this whole process.
And maybe we could follow that up with that question that's right now at the top of the Q&A, which is what kind of professionals were doing the screening? And since 3 of you are on the call, maybe you can share a little bit about that. Or were you, maybe I'm mistaken too, maybe you were just doing the navigation, I'm not sure.
Yeah, I think maybe each of you, if you could just say a little bit about, you know, for how long you conducted the screenings, what your training looked like. There were, you know, and just like your impressions. I think there's a lot of different questions coming up around all of those things.
I can go first. So as an undergrad student, I have, you know, connections, and sometimes you need to have a part-time job to afford things. So I remember having a classmate saying like, hey, there is accountable health communities, they're hiring student workers, maybe you should apply. And I was like, it's COVID, I can't work, and I will appreciate having a remote work, like working from home. This is gonna be great. So I connected with OHSU, I applied, and I worked making phone calls for about a year and a half-ish. I remember it starting on October 2020, so mid-pandemic. So it was a very cathartic process because, you know, you were experiencing all these feelings of, we didn't know what COVID was, but also seeing that other people were feeling similar things was very interesting. So I felt like I was helping, like doing something to move along resources, vaccine outreach. So yeah, as a student workers, that was my experience. Minnie or Melissa, who wants to go next?
I can share next. So like Katherin was saying, I also agree in that it was a very cathartic experience. Like we shared before in our themes, you know, it ranged a lot from patients that it was a very vulnerable time. And I feel that receiving this call, like after moving past that, you know, like, is this a scam? What is this, like after moving forward and generating that report through the call? I learned a lot. I learned a lot in the sense that, you know, people, some people would really open up and they would, you know, share life experiences that, you know, maybe they had an unfortunate situation during the pandemic and it was just incredible to hear that, you know, reaching out at the end of the day, people did utilize the resources and that they were, I recall one caller that mentioned that during the pandemic, her family business was having a really hard time staying afloat, and that through the resources they were able to, you know, they were able to keep it moving forward. And it was just very gratifying to hear experiences like that, just when people would truly and genuinely were willing to open up and share and be receptive of the call and the needs. And it was just great. We learned a lot through the calls. Minnie, I'm passing it on to you.
Thank you. Yeah, so I will say for context too, me and Kat shared an almost identical timeline with Orprin. We both were hired at the same time as student workers, and was working as a student worker for a year making calls. I'd say personally, as far as like volume of calls, I mean, I was like in my senior year of college, so I think I was doing maybe about, I want to say 15 hours a week, and that usually would result in me doing about 20 calls a day, like Monday through Friday. Although you can't predict when a call is going to be 5 minutes or 75 minutes. So obviously that affects the load of calls that can be done as well. In regards to training, I think it was really helpful to have ongoing support. So like, besides the initial training of how to do a call, like having huddles that are happening every week and a lot of like open space in order to ask questions. What was really interesting to me was that as a student worker, my first point of contact was the research assistant for my team to ask questions. And then when I became a research assistant myself, I was then the person who was providing that support to student workers. So it was really cool to see it from that side. And of course, even as an RA, I still had a support person even above me who could help me. So that made things very, very helpful, efficient.
Thank you for sharing all that. Oh, Kat, sorry, go ahead.
Sorry. So for the training, we were able to shadow each other. You know, each people have different approach. So that was always really helpful to shadow other people, of course, with patients' consent, you know, letting them know that there was a person listening. And I think that our team was huge. Like, I can't remember the actual number, but we have 20 plus students making phone calls all over Oregon. Like seeing, one thing is seeing the numbers, right? We're like, oh, we're trending, we have so many numbers, but then you take a moment and you are like, this is not just numbers. These are patients. This is real people who are, you know, picking up the phone and going through the whole survey, the whole, you know, the whole screening. So that was very remarkable. And yes, we have like 20 plus students at some point, if not more. Melissa or Anna?
I'll
just
pass it
wanna-
over to, oh, go ahead, Melissa.
Sorry. I just kind of want to follow along with that. And in one of the comments I saw in the chat about training on empathic inquiry, we were very lucky that we also received support in that regard, especially for difficult calls. It, like sometimes managing that and knowing how to provide even remotely when you're not there, and just how to make the patient know that someone is caring for them, and escalated in a way that was meaningful and attentive to their own personal situation. I was we were very fortunate to also have training in.
The training
There were a
was
couple of
very.
questions. Oh, sorry, go ahead.
I was gonna say the training was very informal. Like first we needed it to get familiar with the screener and how to ask those questions, especially, like the safety questions. And so again, the training was very informal, but also I feel like we also learned from experiences like, hey, I'm having a difficult situation. How do I handle it next time? So it was kind of like trial error, but also like us having the huddles and like talking and having a debrief, especially after hard, difficult conversations. Like I was not prepared whatsoever for what some of the things I went through. And I think that especially for me, like my background is in social work. I was getting my bachelor's in social work, and I was like, I'm learning more about real people through my phone calls to what I'm actually learning. I mean, I was applying what I was learning. But I think that's something that helped me, especially, like with Minnie and our team meetings, was like to make sure that patients were always safe, like first and for the most, because our goal was not just to complete the screening, but also like make sure that they were in a safe environment and that they were able to answer all of our screening questions, because we have domestic violence questions. Also, like some people were very uncomfortable when we were asked them about their income, their yearly income. It was either they didn't know or their partner managed their finances, that like they didn't even know how much income they have for their household. So it was like, how do you navigate those kind of situations? And being flexible, like you don't have to have always everything.
Yeah. I wonder if we can, there's a few questions in there that are kind of about the real basics of the program, like about kind of, what did people get if they screen positive, those kind of things. I wonder if you guys could just hit those kind of quickly so people understand.
Yeah, there was a wide variety across the clinical delivery sites, but I can speak to the way that worked for the 2 clinical delivery sites that we focused on for the qualitative study. So for the quantitative study, it was like all over the board, like all of the different clinical delivery sites had different ways to do that follow-up. There was kind of like a general structure for who would get followed up with, but like the timing of when the follow-up with and who reached out and like how people were connected to resources, like there was a lot of variety in that. And that was not something, as far as I know, that was systematically tracked across the accountable health communities model. For the qualitative study, for the emergency department, those calls to patients coming out of that clinical delivery site would get a follow-up call from 211, which is like a social services hotline that exists in many states. So navigators from that service would follow up as quickly as possible. But I do know that there were large backlogs at times, and so it could be a while. What I found through the calls is that my impression, and Katherin, Minnie, and Melissa, correct me if I'm wrong, but often the navigation would maybe start a little bit on the screening call, like when the resources guide was being followed up with. They would receive the electronic resources guide before the navigation call. So that would give them at least like some, numbers, websites potentially relevant to their geographic area. For the primary care setting that I recruited folks from that were also being called, by the students. Those navigators were community health workers from that primary care system. And my impression through the calls is that they were following up a bit more quickly with their patients and providing a bit more comprehensive navigation when they followed up, likely because of the volume of calls and also because, you know, they're really familiar with the geographic services in their clinic area. So did that answer your question?
Thanks. So following up on that, there was a question about what happens if the resources weren't really available.
Yeah.
So someone mentioned, you know, housing can often be a challenging issue.
Yeah. I mean, and it's often not. This came up a lot in the qualitative interviews as well. I mean, when it comes to what happens, I think that there's like a lot of different angles to that. It's like how you're setting up the call initially, what you're doing to try to connect folks, and then what happens if there's not a resource. So there's like a lot of different things along that continuum for what you can do. So one of our themes was, you know, demonstrating a genuine intention to help, but a part of that was being very transparent about what you could and couldn't offer. So, and you know, to be honest, like people that had needs around housing that I talked to, I think housing in particular, are well aware, like way more so than the healthcare team or the callers, about existing resources in the community. Many of them had already accessed all the resources available through other community-based organizations or through the state. And they were very understanding of the fact that like healthcare doesn't have additional resources for housing. But one question that I asked all interviewees was, should we still be asking about resources even when a resource may not be available? And there was maybe one interview where someone was unsure, but for the most part, everyone that I spoke with basically said, hey, we understand the resources may or may not be available, but we appreciate the intention to try to connect us. And especially when it feels like you're really listening and tailoring it. So it's like, you're referring to a housing authority that speaks the language that I speak, or you're referring to a place that's accessible to me based on my transportation needs so that I'm able to go and check for myself. So people have really realistic expectations, I think, for what healthcare can do. It's just like not making false promises and like really just like demonstrating the care.
And that's great to hear. And that's consistent with a study that we did where we talked to patients, that Siren did, where we talked to patients who were, and asked them about their experiences. And they also said something similar around like they're generally, if it's done in a really empathetic way, they're glad to be asked. They feel like
I do have a couple of like,
also for their care teams to know.
I do have a couple like limitation things I think that are important to note about this study and the people we spoke with. So for IRB and privacy purposes, just to reemphasize this again, we only spoke with people who both, you know, qualified for navigation assistance and consented to be contacted about navigation assistance. So right out the gate, we were only, you know, talking with people in these interviews who were, you know, probably more receptive to the intervention at large and felt better about it. So I think that that's an important thing for future researchers to consider, is like how you capture the perspectives of people that don't want to engage and why. Like that's a challenge, but I think it's like we're missing a lot of important perspectives by not including those folks. The other thing just around the timing of the study was that, you know, I was collecting this data in like the midst of the pandemic, when a lot of people who had never had a lot of these needs before were suddenly out of work and like had food needs, had housing needs. And another thing that came up in the interviews that wasn't in the manuscript, but was that people were like, well, you know, everyone needs help now. So there's no shame in asking for help. Like everyone that I know needs assistance. And so I'm curious about whether that mentality like sustains past the pandemic, if that like normalization of being able to say, yes, like I need help, or if, you know, that normalization goes away. Clearly there remain huge social inequities and needs in our society post-pandemic. But that was an interesting thing that came out.
Yeah, there's a few more questions we haven't gotten to yet, so I'm going to try to see if we can get them. There was one question about the timing for reaching people. So were there predetermined appointment times, or how, you know, did you figure out that there's some good times to call people and bad times to call people? How did you handle when you tried to call people?
I'll leave that to you three.
Go, Minnie. I can go after.
In short, trial and error. I think we did do kind of our own on our team's internal like analysis of, because we would have a log and we would keep track of like what time, so like 1 to 2 p.m., 2 to 3 p.m., etc., of when we were making these calls and then the outcomes of these calls. So like as a research assistant, I was providing that information to my team of student workers to sort of inform like when making these calls is the best. In general, it was like afternoons, kind of like 3 p.m. to 6 p.m. We also, as best as we could, accounted for when you call someone and they're like, hey, I can't do this right now, but like Saturday at 2:30 p.m. I will be free. And we usually, if not always, found a way to be able to do it. If I couldn't do the call, I would ask a colleague, hey, are you available to do this call? So being flexible, but yeah, in general, those like late afternoons were pretty hot spots, I would say.
I
Oh,
don't think.
I can't hear you for some reason, Caroline.
Oh, because I was on mute. I was going to go to another question, but Kat, did you have something else you wanted to say?
I want to answer, but can you please repeat the question? Sorry, really quick.
Oh, the question was about like figuring out when the best times were to call people.
Yeah, I will echo what Minnie said. I think that there were challenges. There were women who were like, oh, we're cooking, or oh, I'm at work, call me later. And so it's kind of like being flexible. And also I feel like since we were student callers, our times were very flexible. So like for me, like the best time hours were like from 4 to 6 p.m. when you know people are getting off from work. So that was helpful. But yeah, it varies. It definitely varies.
That's great. Let me go ahead and ask another question there. So was there any follow through besides the research that you all did in the actual program, was there follow through on resources and referrals to see if needs were actually met? And I think this connects also to another question that somebody else asked about kind of the idea of closing the loop and finding out, like, did you get a resource or not? Was that something that was done as part of the program?
It varied by,
so how?
It varied by clinical delivery site. And I mean, that data did exist and I was excited that it existed. But then when I actually got into the data, I realized that it was mostly open-ended and like very inconsistently inputted depending on the delivery site. And so it would have been difficult to use it in any kind of systematic, like quantitative analysis way, unfortunately.
I will add, and we'll put this in the resources when we send it out, that the latest report of the whole entire Accountable Health Communities model was just published a few weeks ago, along with 2 papers in Health Affairs. And there's a lot of really great information in that report. So we'll put that in the email that we send out next week for folks if they wanted to get into that. There was a question now also about kind of, were there any additional assistance provided to help get rid of barriers, like, for example, transportation in accessing resources in rural areas? Curious if there were, like, did you feel like you needed to do something different in rural areas than in more densely populated areas?
Yeah, I will say that, so an aspect of the Accountable Health Communities model is that, you know, ORPRN as the bridge organization convened, I forget what they were called, but essentially a statewide kind of advisory committee that was made up of, you know, social services organizations, a lot of which were in more rural communities. And so there were efforts throughout the project to try to figure out like how to align efforts of those organizations with the Accountable Health Communities intervention, and it's like alignment between like 211 and those services. But I am not the best person to talk to about those efforts. I would say if anyone wants to reach out to me and get connected to the Oregon Rural Practice-Based Research Network, they can provide a lot of detail on like how they tried to bridge those, referral pathways and, in real time update on what emerging resources were coming about. And of course, like a lot of new resources came to be during the pandemic. So I'm sure there were a lot of efforts around that.
One other question going to the intimate partner violence questions. So I'm curious what the protocols were for if somebody screened positive and said, yes, they're afraid of their partner. Somebody asked that question.
Well, I'll just start out by saying that this was like a very difficult component of the screening tool, which is interesting because like intimate partner violence screening has been happening in primary care a lot longer than screening for a lot of these other things. But in the context of this screener and also the specific questions that were used, I believe Amelia DeMarcus has a great article about this, like about the intimate partner violence questions. But there was something interesting at first where like you needed to get a certain number potentially to screen positive, but you could say, for example, like I'm being threatened in some way and not meet that threshold. And so I know that at one point early on, we did a workaround to make it so there would still be a response, no matter what the score was. But I think the screeners can speak to like how you all handled those situations.
I'm gonna jump in, and I want to be mindful of time. So sorry, I'm hearing an echo. So I think that for us, for the screeners, before we jump into those questions, we were kind of like breathing and like, okay, now I have some safety questions. Is it okay if I ask you those questions now? And the person were like, yeah, no, or this is not a good time. And then we would proceed to ask those 4 questions. As Anna mentioned, so we have them like a score or like they have a certain amount. So how often did anybody have a scream or curse at you, as opposed to how often has anybody like hit you or like physically abuse you? So we were kind of like paying attention of like family dynamics and making sure that we capture that. Melissa, go ahead.
Yeah, thank you, Katherin. I'm going to go ahead and echo that as well. To me, it was a lot of how you introduced that section of the survey. So just, first making sure that the patient or that the person who was participating was in, the right setting. If, maybe their partner was present there, how you introduce, like Katherin was saying, like, so the next part of the survey is going to involve this types of questions. And then from there, you would kind of gauge if it was the right time. If not, you would kind of just say like, can I contact you again? And then for me, like, even though it was not black and white, there was a range. Even if there was one question, I would make sure to include, helpful resources, because, maybe you didn't know that if they were sharing everything. But for me, I personally like to follow up on that, even if it was just one little question or something that indicated a need for that.
Thank you, Melissa. So this has been so great. Thank you all 4 of you for sharing your knowledge and expertise and your research results with us. This has been really, really great, as you can see from all the questions that you've gotten. Thanks to everybody who joined us, and we will be sending out the slides, the recording, and all the resources that we mentioned, likely early next week. Please do fill out our satisfaction poll if you haven't done that yet. And everybody have a really great rest of your day, and sign up for our newsletter if you want to find out about future events.
Thanks so much,
everybody.
For your great questions.
Thanks, everyone. Enjoy the summer.
Thank you.
Yes. Thanks.